Well, good morning, good afternoon, and good evening. Welcome to the 979th day of continuous and uninterrupted Zoom session of Ifph. Let us start today's program with a silent prayer for 1 minute. Thank you. Today we have with us Dr. Sreenivasan, MD, visiting Professor Shivaraj Homeopathy Medical College, Salem, speaker in various conferences in Canada and India, practicing at Chennai and Salem with 22 years of experience. And the subject is fever 3 dimensions. We all know that often the fever are creating panic in not only the patients but also the physicians. That is why it is often said that it is a fever of unknown origin or piracy of unknown origin. So many versions are there. So many scientific and unscientific methodology approach is there, but a comprehensive method is homeopathy, and of course we know that the importance. So on behalf of IFPH, I welcome Dr. Sreenivasan. You can have the platform for next 40 minutes. It's over to you.
Thank you very much, sir. Talking so many times, I feel I am a part of the IFPH family and IFPH team. Dr. Joseph Paul rang up from Canada yesterday and he said, can you talk tomorrow night? We finally used to talk and say in All India Radio or Doordarshan, they invite a special artist, music or whatever, instrumental or vocal. Suddenly, when they don't turn up or when a special artist is not available, they take up the team which is already there in the All India radio station or Doordarshan. They are called as Nilay Vidwan, who belong to that station. So I am like a Nilay Vidwan for EFPH. When a special guest speaker or an outside speaker is not available, myself and Paul is there always to come and engage and organize and be a part of IFPH session. So it's a joy and it's an interesting thing to take up the challenge that comes the last minute and give quality output. And also the title, when I told the title to Joseph Paul, Fever 3 Dimension, we had a hearty laugh. How can there be a 3 dimension to a fever? So we say like people should know, at the same time they should not know. They keep guessing what it would be and provoke some interest so that more people join and be curiously waiting to see what it is. And also it is like the same stuff, only the title is different. Like we use the same batter, make different items in our kitchen, no? Idli, dosha, uttapam, masala dosha, whatever. Batter is same, but the name is different by small additions. So in the same way, this is the same topic, which is very, very well known to all participants here, because all of you are senior practitioners and very seasoned and experienced practitioners. Just that I am putting the same title content in a small different way with a different title. That is the only difference. And soon after my talk with Paul, and also I have sent this photo to Dr. Dhanesh, and he was in a serious mode. He could not immediately catch up what it is, the first slide of my presentation, and then he had a hearty laugh. Participants, you are able to see the first slide?
No, sir, not it.
Now?
Not it started.
No, the sharing process is about to begin again.
Okay.
I'll try myself. If it works, fantastic. Now? Able to see?
Yes, it's open.
So it is my photo on one side and the volume amplifying speaker on the other side. So the doctor community is one which laugh little, they are more serious. So it is a symbolic representation speaker, correct? So it is me as a speaker. Now we'll go to slide 2, slide proper. When I was in Thiruvananthapuram in the last days of March, addressing a group of government doctors in different schemes, and also IHMA Thiruvananthapuram district. And I was presenting cases about fever and how to identify the fever totality, where to refer, how to give remedy, and all that. One doctor asked one very interesting and very important question.
Excuse me, sir. Could you please
Yes.
speak louder? Your voice is too feeble, sir.
One doctor
Good.
asked me, sir, we have to do something very urgently so that fever comes down immediately and we help the patient. I gave an answer to her, and the background is today's presentation. It developed into this presentation today. Most commonly, when patient comes with an acute complaint, fever is an example, say severe coryza, severe headache, severe stomach pain, severe cough, severe body pain, severe joint pain, severe palpitation, whatever. It falls under 3 common categories. Category number 1, it could be just acute only. When an acute remedy is given, everything subsides, nothing comes up. That is possibility number 1. Possibility number 2, an acute goes off, a clear-cut chronic state emerges. That is possibility number 2. Possibility 3, acute and chronic states demands same remedy. They may coexist or come one after the other. These are 3 common category possibilities when patient comes to us with an acute situation. Whatever may be the age group, whatever may be the diagnosis of an acute complaint, sometimes it could be undiagnosed also, whatever may be the gender, whatever may be the background. And practically speaking, all of you must have seen this. When patient consults a homeopathy doctor with an acute complaint, he has overcome certain hurdles or options or possibilities without trying them or after trying them. Most commonly, they do self-therapy. It could be allopathy, homeopathy, Ayurveda, Siddha, Unani, or combined or anything. Some people try Ganapati also, praying to Lord Ganapati. I had been to that Palavangadi Ganapati temple. It was fantastic experience. So people try different pathis, and when they don't get result, they come to a homeopathy doctor in person for consultation and treatment. The other option is suggestions given by relatives and friends. And third most detrimental is Google search. I think we should charge the patient for de-Googling them, removing their Google knowledge half-baked and causing trouble to themselves as well as interfering with treatment. Then when they approach a pharmacy, it could be allopathic pharmacy or homeopathy or Ayurveda or whatever, they try certain things. Next is going to another doctor, allopathy, Siddha, Ayurveda or whatever, nursing homes, hospitals, it could be government hospitals or private hospitals also. Overcoming all these options and hurdles, they consult a homeopathy doctor. There could be fear of disease, fear of complication, fear of complication arising due to other medical systems, and sometimes it could be benefits from homeopathy. Maybe we are the most nearest neighbor and easy access to them, quick access. These are reasons they seek a homeopathic doctor's help in person or over phone or whatever means. So when this background is there, and also the three options. Option one, the fever or acute situation could be merely acute only, or it could be an acute situation. When it is over, the chronic will come up. Or option three, acute and chronic, one and the same. And this will decide what remedy the patient will require, and the follow-up will give us the proper guideline. So fever is one aspect or one common presentation and not the only acute situation. Patient may come with any acute situation, and all the three options common applies to all those acute presentations. So fever I have taken up as an example to impinge the point on the viewer's mind. So fever, when patient present with acute fever, I give them a questionnaire. If patient can read, write and speak Tamil, the mother tongue where I practice, I give them Tamil questionnaire or an English questionnaire where patient cannot read. If patient speak other languages, I encourage them to express it out so that they feel so happy and content that they could talk out what they wanted to say. And then I encourage them to write it, even in very basic English with mistakes also it is okay. Sometimes when patient talk it out, we can get the energy pattern in the patient and the deviation in that, even though the language is different. Carefully listening to them, observing them, watching them, we can get very vital clues that can be used as observational, objective aspect, rubrics, material medical study, and we can use it for differentiation and prescribing. So the questionnaire contains present complaint or complaints, if it spreads, where it starts, how it spreads, how it feels for them, which part of the body is affected. I encourage them to demonstrate to show more precise anatomical location also using their own hand. It is clinically possible, and in most of the cases, by encouraging the patient and relative to use this 3D hand description, we are almost able to pinpoint as similar to that of a CT scan report with hands only. And then what are the different things they ate or drank or did before the onset of complaint, and how much time it took between the cause and effect. And the most important thing is the emotional situation they faced before the onset of complaint, then the emotional description, then the persons involved. I asked them to talk about what was the emotion they had, the thoughts they had, what they spoke, what they did, what was their reaction in that situation. that is more vital, and those things had direct rubrics in repertory and information in materia medica. And this question is followed by changes in their appetite, thirst, sweat, stool, urine, sleep, dream, energy level, thought behavior, and also changes in smell, taste, tongue coat, hearing, vision, and other body parts. So this cluster, changes in special senses, changes in physical generals, changes in other parts of the body are very vital, and these are used as concomitants in the repertory. So what causes, it could be physical cause or mental cause, is used. What increases the complaint is used as aggravation modality. What decreases the complaint is used as amelioration modality. If a clear-cut time modality is available, I give higher value to time modality also. So in this way, the questionnaire, even for an acute complaint, gives a complete, fairly accurate picture of what is the problem. If the answer given by the patient is clear, definite, and intense, I use that information. If it is not clear, not definite, and vague, I give them placebo, review them after 6 hours or 12 hours or 1 day, as the case may be, and wait for the symptom to develop, and then come to right totality, and we do more accurate, sharp, penetrating job than messing up with any vague specifics or trying homeopathic febrifuge, like give aconite first, let us see, give ferrum phos, give eucalyptus, give belladonna. I don't do those things. And those things rather mess up the things and cause delay in recovery and result production. So the questionnaire contains problem, location, probable emotional and physical causes, what time it is more, what causes aggravation, what causes amelioration, and concomitant, and if the problem extends. The fever also extends. I will show you beautiful extensions in the rubric which we are going to see in the case examples. Patients taught me so much than what I read in books and in colleges. When my mind is very calm, unprejudiced, open, and alert and sensitive, I could pick up very, very vital points and see that exactly in the reference book and produce wonderful results. So this is what I do, and I wish the participants try out these things and share your experiences and challenges. Where you have challenges, I am ready to help. So we take up option 1. I am presenting only the essence of the case which I use after taking the full case in the above format. And after my 6th slide, I tell you why I take, even for an acute complaint, so much detail. So here is option 1, dimension 1. Patient presents with clear-cut, sharp, intense acute symptoms, which gives a clear characteristic. I read Hahnemann's 3 major works, Organon, Materia Medica Pura, Chronic Diseases, and also compilation of Hahnemann's smaller writings by Dudgeon in lesser writings. I am not able to come to clear-cut conclusion from Hahnemann's writing what he means by a characteristic. From so far I could read and understand from Hahnemann's writing of these 4 works, I'm not able to very clearly understand what characteristic he means. After reading Hanuman's life history, Life and Letters, C.L. Bradford, I could comprehend what is the relative importance, with what relevance he is talking about characteristics. And one more beautiful lecture is there by Kent, lecture number 63 in his lesser writings, where he gives beautiful definition of characteristics and several profuse examples. It is like identifying a person whose photograph you don't have, whom you never met, and your first time seeing him in the railway station, a crowd of thousands of people. So we identify first by gender, then by dress, then the color of dress, then the footwear, then what is in the hand. By giving so many features one by one, we are able to spot the person we are looking for. In the same way, by adding features to one complaint, fever, how it started, where it is present, how it extends, what time it is more, what makes it worse, what gives relief, what are the accompaniments. So these are features. Adding one by one, we come to understand the individuality of fever, the individuality of the person, and thereby we are able to pick out the remedy which has exact similar individuality, and by giving it, patient is all right. So these are called characteristics, and the case questionnaire helped me to understand the characteristic totality of acute as well as chronic. So here is option 1. By taking the full case, the characteristic available was this. The repertory used is Boger, Boninghosen, characteristics and repertory. It's a wonderful work. Cough chapter, fever, chills, sweat chapter, coryza chapter, and these are example chapters where you can very beautifully make out LSMC come to one remedy or a very small group of remedies they can differentiate, prescribe more accurately. So Boger Boninghosen characteristics repertory is one wonderful work, and in all the 3 cases I am presenting today, I used this repertory as a reference. So the chapter is fever chapter, heat chapter. Very interestingly, the first leg of the characteristic is patient told fever starts in the head, come to the chest, then abdomen, then lower lip. Head, chest, abdomen, lower. Point number 1. And this type of fever is more in the morning hours. When patient says such time modalities, I ask them, do you take anything to reduce the fever? If they say some allopathic tablet or any other medication, the value of those points are very less. So I carefully scrutinize whether the fever is aggravated or ameliorated by any factor or time, and whether it is related to any medication or any act they are doing. Patient said, no, nothing is being done of that sort. Still, the fever is more in the morning, and the fever started after an anger episode. This is there under aggravation, anger after, under fever chapter. And whenever fever is there, there is intense toothache. I examined the mouth, the teeth and gums. All are healthy. There is absolutely no visible pathology with teeth. So there is a characteristic of fever, descending type of heat, which is more in the morning, and this started after anger, and when fever is there, there is toothache. I did both group where I have taken diagnosis and where I am not bothered about diagnosis. The results are really good where I am not bothered about diagnosis. So you all please try two groups where you have made prescription on the basis of diagnosis, where you ignored diagnosis. In the totality, you gave a remedy, see patient better. So in my experience, where I have not included the diagnostic totality, patient did really well. And interestingly, Staphysagria covered all the four rubrics: fever, descending direction, worse in morning, anger after, concomitant teeth pain. After giving Staphysagria, sir, don't bother about the potency or the dosage. The idea I suggest is the method, because potency and dosage comes by application and trial, and it requires time. It's not possible in one seminar or one class like this. So the emphasis is on learning the method and becoming familiar with the book. And the reaction after Staphysagria is profuse sweat. The fever disappeared in reverse order from below up. So here the rule is the reverse order, not that it went from this way, wrong direction. No. So it is in reverse order. And the next morning fever was not there. Patient was able to leave that anger which was lingering, and toothache is also gone. I did not do any dietary change. I did not do any lifestyle change. I did not say you cover the patient. I did not say to do sponging. Nothing of that sort. Very careful observation of patient choices and allowing them to do usually gives amelioration and gives direct rubric. Patient says, during fever, I want covering. Say, for example, patient says, I want fanning during fever. Patient says, I want open air during fever. These could be rubrics of amelioration and priority. And using that, we come to right remedy, and that gives accurate, sharp, quick result than giving advices and change in diet lifestyle. So Staphysagria completed this, and thereafter patient remained free for quite some time. There was no acute complaint, no chronic complaint. Dimension 2. The acute totality of fever was there, and patient did not say, or I would say, I did not inquire carefully to check whether patient had any chronic disease in the background. Patient came for acute complaint. The acute totality was completely taken. Remedy was worked out. The reference book is BBCR. Interestingly, patient had fever only in the upper half of the body. Many times, not only in acute case, but also in chronic cases. The one habit, the one attitude that helped me a lot is being very, very silent, alert, attentive, sensitive observant, and unprejudiced. Patient told very beautiful point, and the exact reference is there in the book. And using it, we come to most wonderful remedy. The fever was in upper half of the body one, like head, chest, and up to umbilicus only. The arms, the entire upper limb, and the back. There is no heat below the umbilicus. Any casual onlooker or any other system doctors will ignore this point. But these are very, very vital and one important link in forming the characteristic totality. So, heat in upper half of the body. The wife told, the heat is there, doctor, I observed, when he is eating food in the morning, afternoon, or neither before nor shortly after that. Only when the patient is eating food, not while drinking. So vital. Had I been very casual and inattentive, I would have missed these two vital points. Fever upper half and the heat is when eating one. Usually he is a bold person, caring person, relaxed person. Strangely, during this fever, maybe because there was some death in the family or in the neighborhood, but the fever came up, fear of, which is a concomitant. If we take a BBCR repertory, we find all these 3 points under fever chapter: fever, heat, partial heat, upper half of the body, rubric number 1, aggravation, eating while, and concomitant, mind, fear of death. Putting these 3 rubrics, the remedy that came was Natsum. It is not always 3 rubrics that give the single remedy. It may be 4, it may be 5. I'm just giving examples. After giving Natswamika, there was quick reaction. Patient had profuse sweat. When patient says sweating, I check with them whether they did anything else to induce sweating to reduce fever. He refused, no, no, sir, nothing was being done. And then the other things also disappeared. Then patient told me in review, doctor, do you treat for diabetes also? I said, yes, very well. And then the chronic case was taken. I just wanted to check whether the acute remedy itself was acting on the chronic state and producing changes in the symptoms, the general well-being in mind and body level, as well as in pathology. But that did not take place. After repeating the remedy in same potency or different scales. So I thought it is time I use chronic totality where generalities were taken and the repertory used was same BBCR. Mind chapter, by nature, he is a timid person. He has very strong aversion for milk and he gets frequent, intense snake dreams, chasing him, biting him, running, or twisting around him. Different types of snake dreams. When patient talks about desire, aversion, aggravation, instead of giving protocol diet chart to patients, whatever may be their chronic disease, either it is diabetes, hypertension, cholesterol, cardiac, hypothyroid, whatever, the homeopathic materia medica and repertory gives wonderful rubrics with remedies. So before endeavoring to give a protocol diet chart, I spot whether we have clear cut desire, aversion, aggravation. When a diabetic patient says, I have aversion to sweet, I check whether because doctor advised them not to eat sweet or whether sweet is causing them trouble. If sweet is causing them trouble, I take sweet aggravation. If they say it is because doctors told me I am avoiding sweet, I ask them, do you like or crave sweet? They say, yes, I crave sweet. I take craving sweets. And I don't go for protocol diet or dietary radical changes or listing. So here, patient by nature is timid. Even though in the acute situation, the wife and himself told is not a very fearful person. Later, he understood that he is a timid person, not having multiple fear, but he is timid. Aversion, milk, and dreams of snakes. And this have not included the present symptoms of diabetic disease. For two reasons. One, it is not clear and no characteristic totality of diabetic disease is available. It is masked. So I put the patient on Silesia. Gradually, we are able to taper and stop allopathic medicines, and patient is taken off from dietary restrictions also, and was advised to go back to pre-diabetic diet to check whether he is able to relish without any complaint or altered sugar levels also. Patient did really well on Silesia. So this is option number 2, dimension 2. This is the most common scenario I came across, because the fever totality is only a tip of the iceberg, and no patient in long years of study and understanding, I came to the conclusion that there is no acute disease without a chronic background. There must be. So we should encourage the patient and relative. They may see us from a different perspective, like monetary reasons also, but there is always a chronic base on which an acute symptom comes up. So it is only a tip of iceberg. The possibility two is very, very important. So dimension 3, where acute and chronic remedies are one and the same. This also occurs. Either we may know it at first case taking or do it as 2 steps. If patient is cooperative and we are also willing and open enough to see whether the chronic and acute remedies are same, we can do this exercise. The case was taken as patient was cooperative. He is a hypothyroid patient. Many a times, an acute complaint, maybe it's a coryza, maybe it is a hoarseness of voice, maybe it is cough. I found there is hypothyroidism. This is an example. It's not only hypothyroidism, it could be anything. So please look for a chronic background even when patient presents with an acute complaint only. The patient has chosen as overcoming so many options I have told you in slide number 2. So we are in no hurry to subdue fever, otherwise they will run away or they will think otherwise. We know what is right, what is best. Patient doesn't know. So I think it is my responsibility to do the work, to do the right work, and then educate the patients. Monetary things come secondary. It is important, but it takes backseat. So here, patient had chronic hypothyroidism. I don't bother too much about the diagnosis, and I don't include diagnostic rubric in the repertory chart. The role of diagnosis is too small, too small. not to bother about the stage, name of disease. So here, the fever was very, very intense and high grade, 104, 5, 6. Sometimes it goes to 6 also. So fever pathological type, the rubric is fever, pathological type, hectic. Strangely, that is what, when I'm very quiet, I heard several times patients say peculiar things. Fever is on only one side of the body. And interestingly, it is on left side one, never on right side. The whole of head, neck, chest, back, abdomen, upper limb, lower limb, on left side, fever is there. This is the only case I saw like that. Never after that, never before that. Yet still, such things are there in patient, such things are there in reference. Fever, partial heat, unilateral, left side. And this comes up or worse in the evening hours. It is either not there or slight at other times. And strangely, during fever, emotionally, she is very sad with or without reason. So what takes over is the sadness. So fever, concomitant, mind, sadness. So this is LSMs. Fever type, exact location, time modality, and concomitant mind. So this is the message today evening. LSMC in fever also. And along with that, when fever is there is sweat in the external hair. Concomitant, the nose becomes dry and there is toothache. The two remedies that was running very close were graphitis and sulfur. And the toothache was the concomitant, where in BBCR, sulfur is not there, but graphitis is present. So I just wanted to check, as patient came forward with a chronic diagnosis, the chronic state of generalities, whether that is also covered by graph factors. Patient is extremely fastidious in all aspects about herself, the documents, symptom presentation, about the family, her daily course in all aspects of her life, social, work, and the family life. And during non-fever phase, strangely, in all seasons, her thirst is more in the morning, whether she eats or not, whether she works or not, whether it is summer, rainy, or winter. Peculiar, her thirst is more in the morning compared to other hours of the day. And how she comes to know about her menses is coming up is she becomes constipated before her menses. So this is one technique I find to elicit concomitant in women.
Excuse me, sir. How much time is you needed, sir?
Okay. So the remedy in acute and chronic state both is graphitis, and that took away the fever as well as hypothyroidism. Patient become euthyroid with same graphitis. So the point is the acute remedy can be curative and preventive of chronic state. So therefore, in one case, you please try when they come for acute, try to elicit the accurate totality, acute as well as look for chronic, and then prescribe and give me feedback. Question, sir.
Yes, a nice presentation, an important topic, because it opens, as said by Kent, the acute conditions opens the case for you. So when you are very, very selective or careful, you can identify the medicine, what the medicine is needed. And Dr. Sreenivasan rightly said about the acute remedy. In case, the second case is from acute to another chronic one, there is a chronic medicine or the remedy that cures total case. So it's time for discussion. Those who would like to participate can go to the participant list and raise your hand. You said about the relevance of this concomitant symptoms and characteristic symptoms. This is a specialty of homeopathy, I think. No other
Yes.
systems of medicine is bothering or they are unable to capitalize on it. Everybody knows because
Yes.
everybody has on or different times might have affected with a lot of diseases. Definitely all these persons were affected and they did felt it, but can't account it. But homeopathy, we can handle it. That's the importance. But what is more needed is that our physicians must recognize how to utilize or the philosophical importance of these concomitant symptoms. That's often missing because we are often prejudiced. As rightly said, how to control the fever, that is the first concern. Because the patients or the physicians are pressurized. Because the other side, the paracetamol stool is there. The opposite side, hundreds of medicines are there. In between the patients, the physician is suffering. So what
Yes.
is needed is a good education, a nice, well-organized training is needed. Yes, sir, please.
There is a question whether constitutional remedy become clear in acute state. Yes, sir, that possibility exists. And if
Yes.
it is there, let us use and see what totality is very clear and sharp and use the remedy. Yes, sir, it is possible.
That is why I just said, Robert Kent, you can see in the lectures, the philosophy of Kent. It is said that often it gives a clue regarding the medicine. It's a golden chance. Kent said it's a very important junction we can identify because the manifestations are very strong and the patient can remember it. They can express it when it's an acute phase. In chronic case, they may not be aware or they just forget about that. The lesser access symptoms may be there. The another questions, in my practice, 2/3 acute cases requiring constitutional remedy. It's not a question. Yes.
Yes, sir, it is possible, sir.
Then another point you said about this, the first important thing is the remedy, then the potency, dose, and attenuation. That's an important thing.
Yes, sir.
Even when the selection is not the right one or it's not the remedy, you might have selected a medicine, but when the compression will totally change when you apply a remedy. So the distance between the medicine and remedy is a lot, a long way to go. A lot of philosophy, a lot of dedication, a lot of reflections, all is needed to select a remedy and an artistic approach. That's all.
Yes.
If anybody would like to participate, the discussions and can ask, because very important, very nice session, and he used to talk about the Boger, Bonius, and supplementary and the concomitant symptoms, the accompanying symptoms, especially the case of the Staphylococcus descending the temperature, how it proceeds, the directions. You often consider the side, but not this one. Whether the upper part or lower part, from lower to upper, that is not often considered, especially because of I think Ken's repertoire is a basic repertoire we are studying in the degree courses. Then we just rush through the other two remedies. That's the point. And unfortunately, majority of our students doesn't have this repertoire. They just take the repertoire from the library and just refer which chapter there, which chapter there. That's all. They then close it. They even don't have it.
At least if they don't give specifics, it is okay.
Yes. Now our Hariharan Saris definitely has got some doubts and additions. Sir, please. Hariharan sir, you can unmute now, sir. Yeah.
Okay. Very nice class. Very nice class.
Thank you, sir.
What I should say? It is the method. It is the correct method. See, find out the symptoms and you convert it as rubric and repartize it and give the medicine. That is the simple method. There is no complication in that. Only thing is you have to find out the exact observation you must have. Where the temperature is? Can you hear me?
Than the patient and relative, the doctor is anxious, sir.
Yes.
What is that?
The doctor is anxious because of his prejudiced mind with connected with pathology.
Yes.
That is threatening him, staring him.
What is that?
Yes, yes, sir.
Sharing.
Sir, please continue, sir. Please.
Sir, see, what the homeopaths are facing now is, see, how to convert patient language to the rubric. That is the one of the one of the difficult thing usually homeopathic doctors are facing. And the observations, and find out the observation and observe the patient, whether it is fever, whether it is colic, whether it is headache, whatever it may be. You have to observe the patient. And that observation should be converted to rubric.
Yes, sir.
And at least 4 rubric, 4 symptoms you must have. Minimum 4 symptoms.
Yes.
See, if you are not getting 4, see, 3 symptoms also we can prescribe by repartizing by the 3 symptoms. With that also we can convert it to rubric and find out the medicine by through the repertory. See, your method is very, very correct. It is the method what Hanuman said.
Thank you, sir.
Everybody is looking for the therapeutics. Everybody is looking for therapeutics. The actual method is what you have said. Your method is very, very correct. Okay, doctor, thank you very much. You come again in this platform and give such lectures. It will enrich us. See, okay. Good night. Thank you very much.
I will come to Thiruvananthapuram 1000th day platform, sir.
Yes, thank you very much. Very encouraging. Yes, now Dr. Marian, do you have something to come? Yes, Dr. Marian, to communicate Dr. Sreenivasan or IFPH. Yes, please. From Bolivia.
Hi, Dr. Manu.
Yes.
Hi, everyone. Thanks for these words. My video is not working. Sorry, I am
problem.
out of phone. And I just want to congratulate all the participants. And you're working so hard. It's really nice every day that you gave us the experts in homeopathy to share all their knowledge and experience. So thank you very much. And I will be pendant of everything that you will require in South America.
Yes, that was Dr. Marian Salcido from Bolivia, and she had presentations in IFPH and treated horses, human beings and animals. We still remembering Dr. Marian. And also she worked to translate. That's an important thing from Spanish to English. It's a great bridge between us and the South America. Yes, thank you, Dr. Marian. If anyone would like to participate or something, you can unmute and 3 to 4 minutes remaining. And we all know that we are about to celebrate our 1000-day program in that in Trivandrum. Internationally, our program is there. It is about, we are all set to celebrate that. So I am expecting your participation all the way. Through your participation and the Monterey support, that is most important, and we expect it. Paris, sir, what is your opinion, sir?
Okay, thank you. Am I audible?
Yes, sir.
Yes, yes. Dr. Sreenivasan, good afternoon. Good evening, sorry.
Yes, sir.
It was a fabulous presentation covering most of the angles of the topic under discussion, mainly distinguishing the acute nature from chronic. I have a question, slightly different from the routine questions from that. I understand that the fever has a positive aspects also, and it helps us to diagnose the exact disease. That's what I understand. So don't jump into treating fever. That is what I understand from my reading it today. I am not a homeopath, but I need not say about the vastness and scope of the topic, requiring further presentations touching untouched areas pertaining to the subject. That's what I said. What is your opinions, Dr. Sreenivasan?
Yes, sir.
Just got a positive aspect. That's what I was thinking to ask you. It not help us to diagnose the exact disease.
When diagnosis is needed, I take the help of allopathy doctor, sir, because I cannot be a specialist of all parts of the body. That is the very reason why allopathy had gone for so many divisions, number one. Number two, the role of diagnosis I use is very, very, very small. Maybe where the first reason where I check is whether patient require any emergency mechanical intervention. It could be surgery or medical. Or whether patient requires any support system. So these are two areas where I use a diagnosis. Otherwise, very careful point which are very peculiar and individualizing automatically heal the diagnostic point also. This we have verified several times.
Yes, that's an important thing, because when you select the remedy, that will automatically within no time you will able to surpass all these difficulties. That's most important thing. Even though the other part is must also be known, but what is more important is beyond all these technicalities, we want to rescue the patient. That is most important. And
Sir,
I think
I answered the question, sir.
Yes,
My answer is clear, adequate?
actually, really, thank you.
yes, sir. You can express a lot of thanks also, sir. Please, sir, please.
Yeah. I have the privilege, the opportunity of this lot of thanks, especially Dr. Sreenivasan, who has made a wonderful and fabulous presentation on the topic, and with a request, humble request to you to have further sessions also covering the other aspects and untouched areas of the topic. All the best, sir. Thank you very much. We will meet at Trivandrum also when you come to Delhi. Okay, thank you. Welcome.
Thank you very much.
Yes, thank you, sir. With that, let me conclude today's English edition. Hope you to meet the same day tomorrow. Till then, goodbye. And it's all Dr. Tanesh for continuation program in Malayalam.